Hello, and welcome back to the ASCO Journal of Oncology Practice podcast. This is Dr. Nathan Pinnell, medical oncologist at the Cleveland Clinic and consultant editor for the journal. One of the strategies that's being tested to bend the healthcare cost curve is moving away from traditional fee-for-service payments through the use of what are known as alternative payment models. The Centers for Medicare and Medicaid Services recently released its goal to move to having 30% of Medicare payments through alternative payment models by 2016, moving to 50% of payments by 2018. One of the routes it's exploring to this goal is by developing something called the Oncology Care Model, which was the subject of a recent podcast in April with Dr. Ronald Klein at CMS. Applications to participate in the OCM are going on right now, and I think it's a very valid question for practices right now. How do they decide whether they want to participate in this? Joining me today are Drs. Arif Kamal and Jeffrey Clow to discuss their paper, The Oncology Care Model, Short and Long-Term Considerations in the Context of Broader Payment Reform, published ahead of print in the JOP on June 9, 2015. Dr. Kamal is the Physician Director of Quality and Outcomes at Duke Cancer Institute. Dr. Kamal, welcome.
Thank you. It's great to join you.
Dr. Clow is an internist and health services researcher, also at Duke University, who recently was a medical officer in the Policy and Programs Group at the CMS Innovation Center. Dr. Clow, thanks for joining us as well.
Thank you for having me.
I have to warn you both, I am a Tar Heel, former UNC grad, so I'm going to work to overcome my anti-Duke bias, but I think we'll probably get by okay on the podcast. So, I think this paper is very topical right now because, of course, practices are in the midst of applying to participate in the OCM. Can we start just a little bit by explaining what exactly is the Oncology Care Model for our listeners who aren't familiar?
Sure. First, I'd like to give just a little bit background about the CMS Innovation Center, which is testing the Oncology Care Model. The CMS Innovation Center was created as part of the Affordable Care Act in 2010, and is generally given the authority to test new payment and delivery models that must either reduce costs for CMS while maintaining or improving quality, or improve quality while not increasing costs. So the Oncology Care Model is one of the latest models to be tested, and in brief, it's what we would describe as a hybrid payment model where eligible practices of oncologists will be given a care management fee, monthly care management fee for episodes of care during which patients are receiving chemotherapy. And in turn, they must meet a set of requirements that were outlined in the paper. They also have the opportunity to earn a performance-based payment if they are able to reduce costs below established benchmarks while meeting quality metrics.
And it's important to point out this is still basically a fee-for-service model. Is that right? So people will still submit bills for charges as they go. And it doesn't currently include chemotherapy charges. Is that right?
Right. So all fee-for-service payments will continue to be paid as usual. The additional payments that are part of the Oncology Care Model will be in addition to those payments. So the care management fees will pay for a number of services and work that currently isn't reimbursed, and the performance-based payment will, of course, be paid based on the outcomes that the participating practices are able to achieve. Okay.
So one of my first thoughts when I was reading this and we were discussing whether to submit an LOI for our own institution was, what exactly, what are the incentives to us to try to participate? Because it doesn't sound, it sounds like there's a fair amount of work that would go into participating in this. So what kind of things should practices consider?
Yeah, so it's a great question, and we struggled with this as well, which is what are the current infrastructures we have in place to inherently meet the requirements of the OCM, and what would truly be new initiatives that we would have to undertake to meet those requirements. So importantly, core functions like patient navigation and 24/7 access to a clinician who has access to the medical record, as well as having a very robust continuous quality improvement program in place, may in fact be programs that oncology organizations are already very well adept at and have resourced quite well, but through internal sources that, as Jeff mentioned, may not necessarily be reimbursed in any model. And so when we look at the potential upside, there is, as Jeff alluded to, a monthly $160 per beneficiary care management payment that is on top of the Medicare fee-for-service, as well as the performance-based payment that really links additional payments to high-quality and lower-cost care. But as every practice needs to do, they need to think carefully about whether that $160, for example, care management fee over a 6-month episode, which is the limit of the episode in the chemotherapy space, so approximately $1,000, makes sense for them and works out above and beyond what is the infrastructure they may already have in place.
And at least it appears that the practices don't have to take on a lot of financial risk beyond the initial investment to get up and running and to qualify for the program. So there's my understanding is there's 2 different risk pathways you can take. One where if you get under the episode goal, you do get this performance-based some sort of a reimbursement of how some element of how far you made it under the cut. But if you don't make it, you don't actually lose any money. But at the same time, there's a second risk model where you can assume some risk and have a slightly better cut point that might be easier to reach. I'm trying to figure out why practices might take on the second one, where they actually might be subject to losing money.
Sure. And I'd like to point out, this is similar to some other alternative payment models, probably most notably the Medicare Shared Savings Program, where participating accountable care organizations had opportunities to select sort of an upside-only model and one with downside risk, but also greater potential for savings. Clearly the benefit of the riskier model is that there's potential for even greater savings, so practices that are very confident or potentially risk-seeking may see a stronger opportunity there. Most likely, most practices will select the upside-only model, and that's consistent with what we've seen in the accountable care organization models, at least until they are able to look at data and become comfortable with understanding how they might perform under the model. Then some may be willing to take on a higher risk model.
And you also mentioned that much of the reward of participating in this model might go to practices that are already have quite a bit of fat to cut, the so-called high-cost practices that need to work on improving their quality and managing their costs, whereas there are many practices that have already been improving quality and cutting costs, kind of getting out ahead of the curve. So are these practices that are really already done a lot of this still have incentive to participate?
Sure. Well, that's a great question, and that's another question where I think it's really important to look at some of the alternative payment models outside of oncology, and this continues to be an issue. Part of the challenge, of course, is that these are voluntary programs, and CMS does have a statutory requirement to ensure that the program is reducing costs. So there's a risk if benchmarks were set based on absolute performance that already high-performing practices would come in and simply get paid without changing behavior. Mm-hmm. At the same time, I think most practices may not actually know where they stand relative to their peers because they're often not receiving data on their financial performance, particularly what's happening outside of the practice, such as with inpatient admissions. Prior research by our team and others has demonstrated that there is a fair amount of variation at the practice level. And actually, interestingly, practices seem to vary in different types of services. So practices that have high levels of chemotherapy and imaging may not necessarily have high levels of inpatient use. So there may be a lot of room for a number of practices. And I think at the same time, certainly practices that already are relatively efficient will at least benefit from the care management fee. It's possible that they've already implemented a number of the strategies that are necessary to achieve that type of performance. But also another advantage may be that through this model they would be able to learn and demonstrate what they're doing and even share that with others and position themselves well within the market. So there are a number of advantages to simply letting it be known that they're high performance practices.
And I might just add to that I think what we're seeing as well is that the OCM model is one example of how one can do this, but it is also spurring lots of innovation just in the general space, where payers are now paying more attention, as are oncology practices, to relationships that may either be outside of the OCM or may mimic the OCM in many ways, but may be tailored to specific populations, specific diseases, or specific demographics that make sense. So in a lot of ways, this is, I think, the entree into a lot more discussion where practices can differentiate themselves from others in their market, can actually formally operationalize a lot of accreditation standards that they are increasingly trying to meet, but have not had any financial backing or, frankly, a financial mandate to meet them. And as well now can enter into relationships where there is transparency regarding quality of care and costs, certainly within the organization. I think we've seen that ourselves, as that has pushed forward a lot more discussion and transparency around what actually are the cash flows in various directions, as well as hopefully spur collaborations within organizations that are aligned with delivering higher quality oncology care.
So if practices want to look at an example of something else similar to the OCM that has already been in place so they can get an example of how this may have worked, one of the things you mentioned in your paper was something called the Comprehensive Primary Care Initiative. And you mentioned that the OCM bears a lot of resemblance to that. Can you kind of explain this comparison?
Sure. So the Comprehensive Primary Care Initiative is also launched by the CMS Innovation Center. It, as the name would suggest, targets primary care physicians and bears a number of similarities to the OCM model. The payment model in general is very similar. There's a care management fee for a set of practice requirements. There's also the opportunity in later years of the Comprehensive Primary Care Initiative for practices to earn a similar performance-based payment based on their ability to generate savings and meet quality metrics. Another feature that's important of that model is there's been a real attempt to bring other payers into the model. So in that model, payers initially had to actually apply, and then markets with significant payer applications were selected to invite primary care practices. And Oncology Care Model is similarly attempting to bring in multiple payers, although it's a little different, and then it's not going to just be limited to markets with sufficient payer participation. But overall, the first-year results of the Comprehensive Primary Care Initiative have been posted, and there are, I think, a number of important lessons in that report. It does seem that the practices have done very well in adhering to the milestones, and there's been a lot of, importantly, retention among practices and among payers. There do seem to be some early results, but it's a little too early to evaluate the effectiveness of the program.
Okay, and you mentioned that you think the OCM might have some advantages over the CPCI, given that it's always difficult to pick out the high and low risk populations, whereas the cancer population tends to be exclusively a high risk population.
Right, that's an important point. Certainly one of the challenges in primary care is to identify the set of patients to whom enhanced services will be targeted. And then, of course, another important difference is that in medical oncology, the medical oncologists directly prescribe and control a number of the expensive services and may have a greater ability, particularly around chemotherapy, imaging, et cetera, to immediately change behavior, whereas primary care physicians often have less direct control over a number of the more expensive parts of healthcare.
So I want to just now move on to the ASCO alternative payment model. So in addition to the OCM, there's also been some attention to ASCO's consolidated payments for oncology care model proposal. This seems to be quite different from the OCM, and ASCO has even been somewhat critical of the OCM for simply perpetuating the fee-for-service model. Can you contrast these two a little bit?
Sure. First, I should mention that in the paper we discussed the consolidated payments for oncology care model, the original model that ASCO proposed. They have put out a revised version of this proposal that's currently out for comment. But specific to that proposal, whereas we outlined one of the key differences is that under their proposal, they would actually bundle many of the services that oncologists provide, particularly the evaluation management services and chemotherapy administration services, but definitely not the drugs or the hospital stays, into a monthly payment, as well as having an additional upfront payment at the beginning of treatment, and then varying the monthly payments on a number of parameters. I think when talking about moving away from the fee-for-service system, it's important to first recognize the value of the fee-for-service system. It is an effective way of processing billions of healthcare transactions each year in a way that generally ensures that people get paid and there's overall access to care. Of course, the big problem with the fee-for-service system is that it provides very little incentive to constrain costs or to improve quality. And so a number of the early experiments of these models really try to correct that latter problem by bringing an incentive on top of the fee-for-service system to minimize the disruption to the processes of financial transactions while participants are basically implementing the delivery changes and trying to demonstrate results. I do think there's certainly some potential value down the road to moving even further away from the fee-for-service system and giving practices even greater flexibility in the way they deliver and are reimbursed for care. However, it probably needs to be taken in a stepwise fashion. And thus far, there's been little success or interest in trying to implement really dramatic changes to the underlying fee-for-service system at the same time as testing a new incentive.
And CMS makes a point that they're testing, I think, as many as 20 different models. Is this something that they plan to test in the future, a bundled payment model for oncology?
Well, I can't really comment about what CMS might test in the future. I think, certainly this is the main model that they have at the current time for oncology. And I do think it's probably important for external stakeholders to work through this model and maybe look at ways to shape this model down the road rather than anticipate an entirely different model to come out.
And I think it's fair to say that everything is really on the table right now, and there's not an end-all, be-all model that I think we've discovered yet, nor will really be finalized, for several years. I think seeing that even ASCO is evolving their model to include supplemental payments that are similar to OCM, while also recognizing that a large portion of costs related to oncology care do occur outside of the usual E&M or outside of the 6-month episode that is for adjuvant chemotherapy, that end-of-life costs, unanticipated hospital admissions, use of acute care healthcare resources, et cetera, should be an area of focus, tells us that I think the models will also reach in those directions. I think we'll also see a lot of leadership from the private payers. For example, the United Healthcare Model reported in JOP from 2014 gives us a really great sense of the role of care pathways and various emphasis on care pathways and sort of narrow approaches to treating very common cancers as another avenue. And I think we'll see mixes of all of these things as new models are proposed and refined and adopted.
Are there any other potential advantages for practices or insurers participating in the OCM that we haven't covered so far? You also mentioned near the end of your paper that there have been changes to legislation incentivizing participation in alternative payment models towards the end of the decade.
Right. So I think we certainly have to mention the macro legislation, which many physicians will recognize as the legislation that removed the sustainable growth rate formula. Of course, that legislation didn't actually fix the underlying problem, which the SGR was built for, was essentially the unrestrained growth in Medicare costs. In place, it put several provisions to move Medicare into a value-based system, one being either an option for physicians participating in alternative payment models, which would come with a bonus beginning in 2019. Another option is sort of a consolidated and amped up version of the value-based programs that are out there to date. I think it's really important for physicians to begin to prepare themselves for 2019 when these come into effect. It's also important to recognize that the types of eligible alternative payment models under the legislation will actually require risk-taking among physicians, which could require something that looks like the second track of the Oncology Care Model. So it really is an important time, not only for physicians to begin to learn how to operate under alternative payment models, particularly in a setting where there's less financial risk, but also to shape the types of alternative payment models and even the types of performance metrics that might take place under the what's termed the MIPS, essentially the other value-based payment option.
So, Dr. Clow, Dr. Kamal, thank you both for joining me today.
Thank you for having us.
Yeah, thank you so much.
I also want to thank our listeners who joined us for the podcast. The full text of this paper will be available at jop.ascopubs.org under early release. Then please scroll down to June 9th, 2015. Don't forget, you can also read the JOP and access these podcasts on your smartphone or tablet with the ASCO Journal's mobile app, available in the iTunes Store and Google Play. This is Dr. Nathan Pinnell for the Journal of Oncology Practice, signing off. Thanks for listening.